cover as well. All right, so these are the conditions that we're going to talk about briefly today. Common elbow pathologies are lateral epicondylitis, medial epicondylitis. A lot of these you've seen already in the past, here and there in some of the courses. We're going to talk about ligament strains, both medial or lateral collateral ligaments, olecranon bursitis, cubital tunnel syndrome, radial tunnel syndrome, total elbow replacement as one of the surgeries that you just saw, and myositis ossificans, which keeps coming up in class after class. So the first one we're going to talk about are lateral and medial epicondylitis. These are both known as repetitive overuse injuries. Overuse because the patient starts with the pain and then is recovering a little bit, decides to go back to the activity that was causing this pain. So they don't actually let the healing process go through for one full cycle before they start doing that activity again. So in these overuse syndromes, what happens is that the new collagen is laid down to begin healing, but the patient kind of goes back to the activity that was aggravating it. So it is kind of like a vicious cycle is what it says up there. With this continuation, with this vicious cycle that the patient is putting themselves under, they continue to create micro tears and obviously inflammation, which is why the patient sometimes has like chronic lateral epicondylitis, because they are not educated properly that they need to obviously stay away from the aggravating activities to allow the normal healing process to take place. So what is extremely important for us to tell our patients regarding lateral and medial epicondylitis?
Not going to do the same activity.
Not going to do the same activity. So this patient's a tennis player. It will be in their best interest for them to stay away at least for, I know it's hard for some patients to stay away if that's what they love doing, but maybe 3 weeks so we can get them to at least the beginning of the chronic stage or the late subacute stages, so that normal healing process can take place. Yes.
Can this be something that even if you get like 3 weeks, 5 weeks, then you'll get it again? Because
Yes.
It's already like.
Yes. Because you're already prone to it, you've already had in the past, and it may just be something that you're going to chronically get. Yes. So the most involved muscles you have to make sure that you know, although it can also involve the extensor carpi radialis longus, extensor carpi ulnaris, and the extensor digitorum, the most involved muscles are the extensor carpi radialis brevis because of the stress on the radial head. So please make sure that you remember the most involved for both lateral epicondylitis and medial epicondylitis, which we're going to be talking about later. Some signs. Obviously, there's going to be pain in that common extensor tendon, possibly in the muscle belly of the involved muscle or muscles. There's going to be pain when the involved muscle is put on a stretch. Do you need me to answer why? Okay, we all agree, right, that you're going to put that muscle on stretch, it's going to pull on that tendon, it's going to pull on that where that is attaching, therefore it's going to cause pain. So do we want to stay away from stretching during the acute stage?
Yes.
During the max protection phase? Yes. Pain when the involved muscles are tested through manual muscle testing. So obviously if they're causing pain, we would just put on the objective section for that day, unable to test, secondary to pain. There's going to be pain with gripping. There's going to be pain with repetitive activity, such as tennis, such as yard work, anything that involves wrist extension. Give me something that involves wrist extension that is not up there. Writing, okay, has components of extension. A lot of things, right? A lot of things that we do in opening a door, depending if it's a sliding door, right? Has a component of extension and also has a component of flexion, bringing that door back to a closing. So there's different things, but what you have to know with lateral epicondylitis, aggravation is going to be caused by anything that you need to repetitively extend your wrist. Okay. The objective data, the data on the right side, is basically what your patient is going to present in the clinic with. So These are the problems that your patient is going to have when you see them for lateral epicondylitis. They're going to have decreased strength in their extensors. The endurance is going to be pretty bad as well in the extensors. There's going to be decreased grip strength, decreased muscle length of the extensors, and tenderness over the common extensor tendon and possibly in the involved extensor muscle belly. So let's say we have a patient. That is the objective data that we see right now in a chart in front of you. How are you going to start to treat this patient, Lewis? Let's say the patient is 5 days after an acute on chronic flare-up of lateral
I
epicondylitis.
would do slight isometrics before I could perform massage.
Okay, so massage and isometrics, all appropriate? Yes. What else can we do, Alex?
If you want to like decrease pain, you can do cold pack.
Cold pack, okay, good. So let's say that now he has progressed, that patient has progressed. It is now 2 weeks later. Everything has calmed down a little bit, but there's still some discomfort. But now there's so much, we're addressing number 1 and number 2 there. There's a lot of decreased strength. How are you going to treat that, Pedro?
You starting like activated motions, or how the patient do activated motion,
Active range of motion, okay.
and then some depending on how far they are in the inflammatory stage or the healing stage, you do resistive exercises too.
Okay.
Or slight resistance.
So how would your resistive exercise, what would it look like? I mean, I'm not giving you a muscle grade or anything like that, but let's say that they're like a 3+ out of 5 at 3 weeks.
For lateral
Mhm,
epicondylitis.
yeah.
You do like maybe like some with a dumbbell. You do some extension.
Okay. In that position that you're in against gravity?
You can be against gravity. Yeah,
Okay.
3+ and
All right. Good. Everybody agree with that? So let's say we're working on how much weight did you decide to use?
The lightest point like 1 pound.
The lightest? Okay. So how do you figure out what weight you want to use, Ricky? Use the DeLorme or use the 10 repetition max, right? That's easiest. See how much, let's start with 1 pound, see if the patient can do it comfortably, easy. If it was too easy, let's bring him up another pound to 2 pounds. And that's how I want you guys to think through in the competency. I chose a 5 pound for Richard, that's my patient. I tried 1, I tried 2, I tried 3, I tried 4 pounds, and he was doing it easily. He did 10 repetitions without a problem. And now the 5 repetition of the 5 pound is the one that I'm going to choose because this is the one where I feel like he's working hard.
Oh, it's come to we actually have to grab all those weights.
You don't have to, which is why I'm telling you, just verbalize that you use the 10 repetition max. And this is how you figured out that Richard is okay to tolerate that 5 pound weight.
Okay.
That you worked through all of those weights before you got to that decision. And you can also throw in the DeLorme method, but we're not asking for the DeLorme, we're just asking for the 10 repetition max. All right, that sounds good. So let's say we're still on the scenario with Pedro, and he decided to work on strength. He decided to use a 1 pound, right?
Yeah.
He's working on strength. Megan, how would my sets and repetitions look for what he's working on, strength?
If it's like his first time doing a strength exercise,
Mhm.
I would bring his 10 rep max. Maybe have him start with 2 sets of 10. And if he could do that, he would go to 3 sets.
Okay.
But the first time you're just monitoring the response, and then he can increase the reps or add another set if he's with no worsen symptoms.
Okay. With that 1 pound, I'll accept that, right? We're just starting, right? Let's say now that he has progressed, Carlos, he has progressed to a 5 pound weight, and he's still working on strength. What do you want to change your sets and reps to look like?
Some more sets for
Or increase the intensity.
Hmm?
Increase the intensity.
I increase the intensity
So you
because
wanna lower the
we increase the resistance.
Lower the reps.
So lower the repetitions is what we want, the rationale we want to hear. When the patient is lifting 1 pound, 2 sets of 10 is fine. But let's say now that we've progressed them to, let's just increase it way more, 10 pounds. Now, since the patient is working more, you want to decrease the repetitions, right? Is that clear for everybody? That's the rationale that we're looking for in the competency when you choose. Please do not be bless you. Do not say 3 sets of 10 just because 3 sets of 10. You can say 3 sets of 10, but you need to tell us why you chose 3 sets of 10. Okay? Yes.
So,
What's-
for example, like when you increase the intensity,
Mhm.
are you still trying to keep it like the same volume? Not that high for 3 sets of 10 is like 30. Now that we're doing maybe like 5 repetitions,
You can do 3 sets of like 8.
are we trying to keep it with the same volume or it doesn't really matter?
It doesn't matter. As long as the rationale behind it and the book has it that strength is higher intensity or resistance and lower repetitions. And when we do endurance, it's just decrease resistance or intensity and increase the sets and reps. Okay. Yes. Can you do Russian instant? Yeah. Yeah, absolutely. Yeah. All right, so that addressed decreased strength. Richard, how would you address decreased muscle endurance? This is for the flexors or extensors, guys? The extensors, because lateral epicondylitis.
They get a TheraBand and keep doing reps, high reps with the TheraBand.
Good, perfect. So that's what I want to hear. Definitely the high repetition counts. I think Dr. Ekborn, that PowerPoint was like 40 to 50.
40 to 50.
Repetitions. Never gets that high in clinic, but that's textbook. But just you can do the 40 to 50 that Dr. Ekborn mentioned in the lecture. Yes. Decreased grip strength. How would we work on that, Rami? They have decreased grip strength, not to decrease it, to increase it.
Decrease grip strength. You can just do the ball.
Okay, so like a stress ball kind of thing. It can be therapeutic. They can just squeeze therapeutic. If there's no therapeutic in your clinic, you can have them ring a towel, like just roll a towel. TheraWeb, we have one in the lab. Yeah, I'll take a. Oh, the dynamometer? Yeah, that's to assess the grip strength. So you definitely use it, but not for an exercise. Yeah. Farm,
Farm carries.
show me what that is.
It's like
You just walk on it.
Just walk? Oh, farmers, yeah, farmers carry.
I heard fire intensive.
Fireman, it's called fireman and farm.
Okay, I've heard it as farmers carry. Yeah, but that's a lot of components there. If your patient's good with balance and all that, and yeah. Decreased muscle length. I don't even have to discuss that one. What are we gonna do for that? Stretch. What did you say? Strengthen? And then tenderness over the common extensor. I think somebody already talked about massage, but obviously we can do massage, we can do ice, we can do modalities to try to decrease some of those symptoms. Okay, good. So special tests for lateral epicondylitis are the lateral epicondylitis test. Don't expect this on a test because it's the name, it gives you the name in the test, or the Cousins test. So this is what we talked about already. During the acute stage, it's very rare that a patient will come to see or seek physical therapy treatment or medical treatment during the acute stages. Why? Because we are just like that as human beings, right? We don't go to the doctor unless you're a hypochondriac for the first sign of something. So patients will go to Walgreens, they will take anti-inflammatories, they will put arnica, they will put a brace on it before they even go to the doctor. But if you do see your patients out there during the acutes, basically the goal is to decrease edema, to decrease pain. How is this done? Through modalities, right? Modalities some manual therapy if they tolerate it, passive range of motion. Immobilization, I'm against immobilization unless it's like actually um, protecting something and keeping it together during the healing process. But some doctors and some therapists say immobilization is good. What does immobilization cause? Contractures, it causes atrophy, it causes lengthening of some areas, weakness of some areas. So that's why I take immobilization only when it is actually completely and utterly needed. You want to use non-painful isometrics or gentle muscle setting, as you also know it. You also want to keep the surrounding joints moving, and you want to educate the patient on what to avoid. So stay away from tennis, stay away from yard work, stay away from bringing your wrist back, at least for a couple of days or even a couple of weeks if you can. It's our hands, so we use them every day. So it's really hard to kind of stay away from some things. During the subacute and chronic stages of lateral epicondylitis, this is typically when the patient will come into the clinic, which we can also treat them with modalities, and you have them listed there. As far as therapeutic exercises, you want to stretch the wrist extensors. You can begin with the elbow flexed and the forearm pronated, and then progress to the elbow extended. With the elbow flex, it just gives a little bit more slack and less pain in that area versus the elbow extended. You want to strengthen the extensors. And this right here is the normal progression that you should take with all of your treatments for all of the joints, right? For all the muscles. So we start with isos. We continue with multi-angle isometrics. We continue with active assistive range of motion. Then if our patient is good with active assistive, we move on to active range of motion. And then finally, we add resistance. So please know that sequence for therapeutic exercises. That's what we start with is the easiest, and obviously we get to the more difficult for our patient, which is resisted exercises. It is also important to work on endurance of the wrist extensors. And Richard brought up a really good point, bringing it forward from modalities. You can combine these exercises with electrical stimulation for motor contraction when it is not contraindicated for your patient. So you can use your Russian, your asymmetrical biphasic to elicit these contractions when needed. Extremely important to remember that if your patient has any pain with any of the above that we've talked about, then obviously you want to back down. So let's say your patient progresses well to resisted exercises, but one day they have a setback. What are you going to go back to? Active range of motion, right? Or decrease the resistance and see if that works. This is the importance of you being comfortable with the progressions and the regressions of your patients. Splinting, I don't know if you've probably seen this out there. This is a splint or a brace that is placed over that area. It just reduces the mechanical force on the tendon, and sometimes it works for patients, sometimes it doesn't. They sell it over the counter. And it's just to decrease some of the tension and obviously some of the pain that the tension on the tendon may cause to the patient. Patient education and home exercise program is very, very important. During this comp, you have to give your patient a home exercise during the actual comp, as well as in the SOPLIT. So just to give you an example, let's say that my treatment was to strengthen the biceps brachii with a 3+, to strengthen the wrist extensors with a 2- out of 5, to stretch the lats and to stretch the triceps. On your plan of care, it'll say exactly what it is that you have to do. So strengthen one, strengthen another, stretch one, stretch another. And then it says HEP for stretching. So I have to, before my patient leaves, give my patient a home exercise program for stretching, whichever muscle I choose. So I'm going to choose the lats. So Lacey, before you leave, I want to show you the stretch. I want you to go ahead and just stand against the wall. And what you're going to do is get a towel and you're just going to roll it up, right? When you start feeling a stretch, and then you're going to go a little bit further. And when you start feeling that stretch and you can't go any further, you're going to hold that for 15 seconds. And then you're going to bring it right back down. And you're gonna repeat that 3 times for 15 seconds, one in the morning and one at night. So I would have her demo that stretch for me before she leaves. It is cueable if it is not cueable if you forget that part of the comp, but it is cueable if you do not tell your patient to demo it back to you. Okay, and if you're doing it incorrectly, obviously, there's also cues for that.
So we don't write it down, we just tell them, we show it to them and we tell them.
During the comp itself, you show them one HEP, but in the soap note, you do like you've normally done, right? Your 2
So you
exercises.
can just do that at the end of
You can do it at the end.
Oh, there's some no first come?
Yes. There's a soap note for the comp that's due 1 hour after the comp. Okay, so you don't want to allow the patient to return to the activities until the patient has full wrist flexion and no pain with wrist MMT. Gradually go back to the activities or the problem is going to return. We continuously educate the patient on that, but do we have full control over our patients? Absolutely not, right? But we educate, we document, and that's our part. The patient has to do their part once they leave your clinic or your office. You want to tell the patient to warm up before doing the activities that previously irritated them. Any questions about lateral epicondylitis? So medial epicondylitis is quicker because basically it is the same exact treatment that you have for lateral epicondylitis. You're obviously now treating the flexors instead of the extensors. It is still an overuse injury due to repetitive wrist flexion, repetitive pronation, repetitive gripping. Most commonly, please remember, once again, the muscles that are involved are the flexor carpi radialis and the pronator teres. It can also involve the flexor carpi ulnaris, as well as the palmaris longus. This is common in golfing, pitching, work-related grasping, shuffling papers, lifting heavy objects, or eccentric strain of the muscle, the musculus tendinous unit. Signs and symptoms, similar, but now they switch over to the common flexor tendon pain, possibly in the involved muscle bellies, pain when the muscles of the flexors are put on a stretch, pain in the flexors and pronator muscles with the MMT, pain with gripping, repeated wrist flexion and pronation, and there may be some ulnar neuropathy as well. So this is the objective data, same exact thing as we looked at for lateral, but now it's the flexors. So there's going to be decreased strength of the flexors, decreased muscle endurance of the flexors, decreasing grip strength, decreased muscle length, and tenderness over the common flexor tendon, possibly in the involved muscle belly as well. The test for medial epicondylitis is the medial epicondylitis test. What do you think is being done in these special tests to try to elicit pain? They put it on stretch, right? They do the thing that we shouldn't do when the patient has medial or lateral epicondylitis. They put it on stretch to see if that reproduces some of the symptoms that the patient has.
So it's stretch for both, or lateral or medial?
Yes.
That's a-
Yes. So treatment of medial epicondylitis is the same thought process as lateral epicondylitis, except you're working with the wrist flexors and the pronators. And for subacute and chronic, same exact thing. You're just now working with the wrist flexors and pronators. So it's the same treatment, just different location and different actions. All right, so we're briefly going to also discuss medial and lateral collateral ligament sprains. Medial collateral ligament or valgus stress overload is just overload to the medial collateral ligament and the medial capsule. So if my elbow is in a valgus direction, is it going to be coming this way or is it going to be coming this way?
It's gonna be out with this.
Valgus. Inward.
This.
So it's going to be coming this way, right? So cubital valgus is the second picture that you see there in the bottom right-hand corner. So with that stress, where does the impact have to come if I were to get a tear or a sprain of the medial collateral ligament? On the outside. So somebody has to come and physically push my elbow in, and then that will cause a valgus stress overload, which will, if the force is hard enough, it is going to possibly tear, if not just sprain the ligament, the medial collateral ligament. The special test for a valgus stress is called a valgus stress test. Basically, what the therapist is doing is pushing into that valgus direction. There may be some gapping in the medial joint if there's a lot of laxity in the ligaments, or there may be some pain in that area. To treat both medial and lateral collateral ligament sprains, basically you want to think of the healing stages that you went over with Dr. Ekpo last Friday. And obviously you want to avoid any type of activity that is going to increase that valgus stress. Now we go over to the other side, to the lateral aspect. So the lateral collateral ligament is pretty uncommon that it is sprained, but obviously it will be with a laterally directed force, right? So somebody coming at you from this direction, pushing you into that direction, and that's going to stress the lateral collateral ligament. The test is called the Vera stress test, and again, it's just pushing into that direction, and you may see a little bit of, feel a little bit of gapping at the lateral joint and some pain. So everybody clear on cubital valgus, cubital varus? Yes? And what is stressed with both directions?
What do you mean by what is stress?
So with a valgus directed stress, the medial collateral ligament is stressed. With a lateral directed, the lateral collateral. And there are obviously some students are surprised when I say lateral collateral ligament of the elbow. They just thought there was only one LCL and one MCL at the knee, but there are in different parts of the body. So always ask, or if it's not specified in a patient's chart, if you're working with the knee, you obviously know it's MCL, LCL of the knee, but if you're working with the elbow, MCL, LCL of the elbow. Okay, the next condition is olecranon bursitis, and this is generally caused by prolonged leaning on the elbow over time, but it can also occur from trauma. So if somebody falls for some odd reason on their elbow, that can cause the bursa to get inflamed. Signs and symptoms are going to be pain over the olecranon process with notable swelling, pain with active elbow extension, possible pain with elbow flexion. So this right here, this condition, do you think this would produce a capsular loss of motion or a non-capsular loss of motion, a range of motion? Why capsular? If this bursa is not in the capsule. It's surrounding it, but it's not in it. This is a non-capsular pattern. This is not a question that I'm going to ask you on a test or anything of that sort, because really don't consider it non or capsular, but I want you guys to be completely 100% clear of what a capsular pattern is and what a non-capsular is. When it is a non-capsular, it means that it's a problem happening outside of the joint capsule. When it is a capsular range of motion loss pattern, it's happening inside of the capsule. And the only ones that we've talked about having capsular so far to this point have been frozen shoulder. Frozen shoulder because those adhesions are inside, are deep inside that capsule. So again, just a reminder, please review the capsular patterns for frozen shoulder. So with the signs and symptoms that we see here for olecranon bursitis, what would you do with this patient? Let's say that your plan of care says diagnosis, your chart says diagnosis of olecranon bursitis, still inflamed, and your plan of care states modalities, therapeutic exercise, and pain reduction techniques. Cryotherapy, good. As far as exercise, would we do much with this patient? The patient still has a lot of swelling, right? The patient has pain with elbow extension. Can we do a little bit of passive range of motion? Yeah, to pain-free ranges, right? What else? Can we do massage? Probably not, right? It's what?
It's too difficult.
It's too difficult, right? So you have to kind of work around. You're not going to just come bring this patient to the clinic just for modalities. You can do passive. You can do maybe gentle isometrics. Maybe you can work on the wrist. Maybe you can work on the shoulder to try to strengthen the surrounding joints. But there's always something to be done, especially during this time where we are just waiting kind of for that inflammation to die down. If it doesn't, then the patient may even need an infiltration where the doctor just removes the fluid from that bursa. Yes.
Can we use electrical stimulation for the swelling?
You can, yeah. Yes. All right, our next condition is cubital tunnel syndrome. Cubital tunnel syndrome is irritation of the ulnar nerve in the cubital tunnel. Elbow flexion is going to decrease, to increase this compression because it decreases the space because the fascia becomes tight when we flex our elbows. This can be caused by fractures. It can be caused by subluxation of the ulnar nerve over the medial epicondyle. It can be caused by facial tightness. So if my patient has just overall tightness of their fascia, that may compress that area where that ulnar nerve runs through. Cubital valgus. How would cubital valgus cause this? The nerve is stretching, right? So cubital valgus, the joint is being pressed into a valgus position, and that's going to compress this area more, causing more tightness in that tunnel where that nerve sits in. Repetitive elbow flexion and extension activities may cause it, or constant pressure over the elbow. Constantly on a desk and you're sitting like this, you're going to have symptoms of cubital tunnel syndrome. That's just a mechanical compression, so you remove your arm from there and you're going to be fine, right? But if it's a constant, you're constantly on a desk and constantly placing your elbow like that, that's going to be an issue. That's going to become an issue for you. So with cubital tunnel syndrome, there's going to be ulnar nerve weakness. So any of the muscles that are powered by that ulnar nerve are going to be affected. Ulnar nerve paresthesia, typically in the 5th digit and in the ulnar half of the 4th digit. Please circle that. You have to know specifically where the paresthesia is going to be happening. There's going to be weakness in grip and wrist flexion. Again, medial epicondyle, directly attached to my wrist flexors there. There's going to be pain at night, especially when the elbow is flexed. Richard, why when the elbow is flexed? Compression. You're just increasing that facial tightness, right? So definitely, what will we educate our patient to do at night to decrease these symptoms?
Keep them straight.
Keep the arm straight, keep the arm out, so to prevent that compression from causing you discomfort and causing you lack of sleep. So that will be in our education for sure for these patients. The special test for cubital tunnel syndrome is a Tinel sign. The Tinel sign is basically just tapping over that nerve. The Tinel sign can be used for carpal tunnel syndrome if you can tap over that area. It can be used for cubital tunnel syndrome, and it's also used for the next condition that we're going to be talking about, which is radial tunnel syndrome. So radial tunnel syndrome, where does the radial nerve run through? So the ulnar nerve was the medial epicondyle. The radial tunnel syndrome is now over around that lateral epicondyle. So basically this is the same condition, now it's just on the other side. It is compression of the radial nerve in the radial tunnel, which is approximately 4 centimeters distal to that lateral epicondyle. It can occur as it enters the supinator muscle called the arcade of Froge or in the general vicinity. Since it is so close to the medial epicondyle, what do you think this is often misdiagnosed for? Lateral epicondylitis. So it is often misdiagnosed for that, but the thing is that with lateral epicondylitis, there is no nerve paresthesia symptoms or anything like that typically. So that's the big difference in how they can kind of differentiate, how the doctor can differentiate between the two. For aggravating activities, for radial tunnel syndrome, obviously any repetitive activity, any supination and pronation, pushing, pulling, or gripping may cause this condition to worsen or those symptoms to be more prominent in patients. So the signs and symptoms, as you've already established, they mock the symptoms of lateral epicondylitis with these following exceptions. Please know these following exceptions because this is how I know that you know the difference between lateral epicondylitis and radial tunnel syndrome. With radial tunnel syndrome, there's tenderness over the radial tunnel rather than the lateral epicondyle. There's going to be pain over the radial tunnel with resisted MMT of the supinator. There's going to be weakness of the muscles innervated by the radial nerve. And generally, they do not have radial nerve sensory issues as the cutaneous portion does not run throughout the tunnel. It is difficult to diagnose as lateral epicondylitis, but nerve conduction testing is the key indicator that it is decreased nerve conductivity, but these tests are not always accurate. Nerve conduction testing is basically like needles that they put into the muscle to see the neural activity of the nerve running through those muscles. Treatment for this, obviously you want to use your same concepts of acute, subacute, and chronic. You want to think that you want to stretch and strengthen muscle imbalances. They may benefit from neural mobilizations, and you want to avoid aggravating activities. And tomorrow when I cover lecture, we're going to talk about neural mobilizations. They're basically stretches for your nerves. You put your arms in different ways and you feel the distribution of the nerves. Yes.
For their mobilizations, do you like ideally want to put the spot in open pack position in the space so that it decreases the compression of the air?
No, it's just certain positions that we put the joint in to stretch that nerve. And it's really odd positions. One of them is kind of like bringing your hand in this position here, and you feel the distribution of one of the nerves. We do sciatic nerve glides. So I'm gonna give you a handout with just 3 of them so that you can actually feel that. Okay. But it doesn't correlate. To answer your question, it does not correlate with an open or closed pack position of the joint. All right, so we're going to talk a little bit about the total elbow arthroplasty. This is just as with the total shoulder. It has to be that that patient has severe joint pain, severe articular degeneration with a subsequent loss of function. There has to be gross instability. Maybe the patient has non-unifying fractures or severe limitations of range of motion for the patient to be a candidate for this surgery. So these are just some pictures of some of the components. The ones that you saw on the video were a little different, but again, each surgeon may utilize a different material. The patient may not tolerate a certain material. So all these, there's so many different components out there. So the types of total elbow arthroplasty, both are semi-constrained to allow for some varus, some valgus, and some rotation. They can be articulated or linked. These have inherent stability from 1 or 2 pins, or they can be non-articulated. So there's really not a full long list like we talked about the semi-constrained, unconstrained. Here, it's basically, are they going to be articulated or linked together, or are they going to be non-articulated or unlinked? So it just depends on the patient. It depends on the surgeon. It depends on the strength of the surrounding tissues that are going to be placed around that component and the joint congruency as well. There are some new hybrid prosthetics components out there that can be linked or unlinked. It is determined during surgery what the doctor will do. At this time, the total elbow arthroplasty is cemented due to issues with failure when using osseous growth types. So I'm gonna just talk a little bit about what that means. Osseous growth type means, let's say that we have, and Dr. Echo will talk a little bit more about this next week when she does lower extremity. But there are cemented components. Let's say we're talking about a total hip replacement. They drill a hole into the femur to insert that femoral component. And before they put the component in, they fill the hole with cement and then they push the component down. That is a cemented arthroplasty versus a non-cemented arthroplasty. It is now a component that has little holes in it. They just push it into the opening of the femur that they created, and they hopefully will, that patient will be healthy enough for that bone to grow into the holes of that component. So who decides that? The doctor. Obviously the doctor, how healthy your patient is, how good their healing is. So that's all decided at the time before the surgery, obviously. Would everybody understand what the cemented versus non-cemented means? Okay. With non-cemented, there's no cement. Basically, you just put it in there and allow the bone to grow into that component. Okay. So this is the procedure. No, I'm not testing you about the procedure or the what is being done, but this is just so that you know what happens during that procedure of total elbow arthroplasty. There is a posterior longitudinal incision, sometimes lateral, sometimes medial to that olecranon process. The distal attachment of the triceps, as you saw there, that was detached. It can be split, it can be retracted, or it can be spared. Spared is just a new approach that preserves that attachment. It's helpful to patients because obviously that's another thing that they have to go through. Another hurdle is the healing of that triceps being reattached. There will be resection of the distal humerus, the ulna, possibly the radius. Then they prepare the intermedullary canals, which is what you saw when they were kind of drilling into those intermedullary canals. And then the prosthetic components are then cemented in place if they are using a cement. Actually, all of them at this time are cemented for total elbow arthroplasty. But that's not the case for shoulder or for hip or for knee. Potential surgical, post-surgical complications, joint instability, subsequent dislocation or subluxation. If they detach the triceps, there may be some triceps dysfunction. There may be partial or complete rupture of the triceps tendon. There's going to be weakness, obviously, because that muscle is going through some healing as well, because if they reattached it, reattached it, or spared it, or cut into it. And obviously with all joint replacements, there's always the possibility or complication of the implant loosening, or sometimes even the patient's body rejecting the material that the doctor used. Post-surgical management, please review table 18.2 on page 638. And also the precautions. I will be putting some questions regarding those boxes, so please don't overlook that. I haven't really asked you to read much of the book, even though you should be anyways, but please look at those pages. Contraindications, you have to know like the back of your hand. Contraindications, and these are forever. Any high load PREs. What are PREs? Progressive resistive exercises. So any high load progressive resistive exercises, any heavy lifting, or any high loads or impact. So no golf, no throwing. What if your patient was an avid golfer? And that's what they loved to do. And that's what they lived for.
Use your other hand.
Okay. They can do Wii golf,
That's what I was gonna say.
right? Or simulated golf, which they don't have to be that. It will not be the same, but it's an option that they have that you can suggest. Start using your legs. All right, I believe this is the final one. Myositis ossificans. What is this? You tell me, because I don't want to have to say this again. Bone growth in the muscle, right? It's mostly often found in the brachialis muscle. It can develop due to trauma, fracture, muscle tear, or sometimes aggressive stretching may cause this. Signs and symptoms: extension of the elbow is limited, greater than flexion, but basically it's applicable to whatever muscle it's in. It doesn't just happen in the brachialis, but it is most often found in the brachialis. MMT of the elbow flexors is going to be painful. Again, there's bone growing in the muscle. That's going to be painful. It's going to be limiting. There's going to be tenderness when you palpate the muscle belly, and you may, depending on the size of it, feel a bony prominence where there should not be a bony prominence. 80% of these are reabsorbed. If they are not harmful, then the doctor will kind of just watch it. But if they start becoming very harmful and not allowing the patient to have their full functional range of motion, then surgery may be an option. So management of it, contraindications include massage, superficial or deep heat, stretching, resisted exercises, contraction of the muscle. So you say, what can we do for this patient? During the process of an active myositis ossificans, when it is still there, when it is causing all these symptoms, we do not see these patients in PT, all right? But when the patient, occasionally when the patient has surgery to remove these, or they're too large to break down, then after surgery we can see the patient for treating the atrophy, treating the lasting effects of the time that the patient had this in their muscle. So biggest thing to know here is during the active process, we don't treat them. Okay, so that was the elbow. And any problem with your elbows, any problem, well, we're going to talk about wrist and hand tomorrow, but any problem with the elbow can lead to functional problems in your patients. So what functional problems you should see with your patients with elbow pathologies: turning a door, opening their house with their key, pain with pushing and pulling doors, restricted ability with grooming and eating. So this should give you a couple of functional exercises that can translate into the lab when we start the elbow, forearm, wrist, and hand. Pushing from a chair, carrying objects, they're going to have limited ability with reaching, and there's going to be restrictions with eating and grooming as well. And these are just a comprehensive list of the special tests for the elbow. Your skills check is due Thursday, correct? Thursday.
Is it Thursday like 8 a.m. or?
I have to check with Dr. Eckel, so I'll let you know today. Has everybody gotten into the application? So please do not wait for like Thursday morning. Just try today, and if you have any issues, we'll kind of troubleshoot with you. We're still troubleshooting with it because we just decided to do this